Today we are going to discuss about the common neck swelling. Before we touch the neck swelling, it is very important to know about the anatomy of the neck. As you know, neck it ends at the level of the clavicles and starts at the level of the mandible. If you divide the neck in two halves, the ipsilateral half of the neck is just like a quadrangular space. Superior boundary is the inferior border of the horizontal ramus of the mandible, and from the neck, from the angle of the mandible to the tip of the mastoid process. So this is the superior boundary of the ipsilateral half of the neck. The medial boundary is the midline from the symphysis menti to the suprasternal notch, and laterally is the interior border of the trapezius. This quadrangular space is divided by the presence of the sternocleidomastoid, which divides this space into two triangles, anterior triangle and the posterior triangle. The posterior triangle is bounded interiorly by the lateral border of the sternomastoid, laterally the interior border of the trapezius, and inferiorly is the clavicle. The important structure which are present in the posterior triangle of neck, one is the lymph nodes. The L5 lymph nodes, the lymph nodes in the posterior triangle is the most important constituent of the posterior triangle. The second one is the brachial plexus and the spinal accessory nerve which supplies to the trapezius. In addition to that, there are also two important blood vessels, that is suprascapular and transverse cervical arteries, which arise from the first part of the subclavian artery that also traverses the posterior triangle. The interior triangle is further divided into different triangles. One is the submandibular triangle, and this submandibular triangle is superiorly inferior border of the horizontal ramus of mandible, and then the interior and the posterior belly of digastric muscles, which is called submandibular triangle. The submental triangle is in the midline, bounded on both sides by the interior belly of the digastric, and the inferiorly is the hyoid bone. The other triangle, which is called as the carotid triangle, that is a part of the interior triangle which is bounded again by the sternomastoid and the inferior border of the superior belly of the digastric. These are different triangles. In the interior triangles, in the submandibular triangle, you have got a submandibular salivary gland and the submandibular lymph nodes, which lying on the anterior surface of submandibular salivary gland. In submental triangle, you find mostly is the fat of the submental group of lymph nodes. If you look at the superior boundary of the quadrangular space of the ipsilateral half of the triangle, from the angle of the mandibular tip of the mastoid process is an imaginary line, and you find the tail of the parotid also comes in the upper cervical part of the neck. The important structure in the anterior triangle is the carotid sheath, that is most medially the common carotid artery, then the vagus, and laterally is the internal jugular vein. And of course, the lymph nodes are also present along the sides of the internal jugular vein underneath the sternocleidomastoid. So we will first discuss about the cervical swelling in the midlines. The common swelling in the midline is which is above the level of thyroid cartilage, near around the hyoid bone, is the thyroglossal cyst. The thyroglossal cyst is the vestigial remnant of thyroglossal duct. This swelling is usually present around the hyoid bone, midline swelling in the majority of the patients, usually below the hyoid bone and sometimes is above the hyoid bone. The thyroglossal cyst can be present right from the foramen cecum down to the cricoid cartilage, but the commonest place is around the hyoid bone, usually below the inferior border of the hyoid bone. This hyoid bone is developed later on from lateral to medial sides, and that is why it incorporated the submandibular, what is called thyroglossal duct. The thyroglossal duct tract is incorporated in the hyoid bone. The second swelling which can be here in this area is the ectopic thyroid, because the thyroid gland does not descend to its normal position, so it can be arrested anywhere. So that is also a site of ectopic thyroid that can also present as a rounded swelling in this area. The third swelling which can you see in the midline around the hyoid bone is the dermoid cyst. And other swelling may be hypertrophic pyramidal lobe, which is present in this area. This differential diagnosis you should keep in mind. The thyroglossal cyst is deep to the strap muscles. So if you ask the patient to swallow, the thyroglossal cyst moves up with deglutition. And if it is also a pyramidal lobe, it also moves up with deglutition. If it is ectopic thyroid, it also moves with deglutition, because as they are wrapped in the petechial fascia and they are deep to the strap muscles, they do move with the deglutition. The enlarged lymph node in this area, sometimes the pre-laryngeal lymph node, it's called Delphin lymph nodes. The point to differentiate between the thyroglossal cyst with the other swellings like enlarged pyramidal lobe, ectopic thyroid, and the thyroglossus cyst is, if you ask the patient to open the mouth and protrude the tongue while you are holding the cyst or swelling in the midline, upward tuck is a diagnostic sign of the thyroglossus cyst, because when you protrude the tongue out, as it is attached to the base of the tongue, so when you protrude the tongue out, this swelling moves up. The upward movement on protrusion of the tongue while you are holding the swelling is a diagnostic feature of thyroglossus cyst, which will not be present in the enlarged pyramidal lobe and even ectopic thyroid that doesn't move upward on protrusion of the tongue. It is only a classical cardinal sign for thyroglossus cyst that it moves up or upward tuck is diagnostic, upward movement is diagnostic of thyroglossus cyst. Regarding the dermoid cyst, if it is below the level of mylohyoid in the area of the hyoid bone, it does not move on deglutition because it is the outside the staph muscles in the skin. And number two is there is no positive sign upward tuck on protrusion of tongue. When you protrude the tongue out, this swelling does not move up. It is a swelling which is present in the skin and the subcutaneous tissue. It is the dermoid cyst which contains the skin and the skin appendages like sweat or sebaceous gland, and this is usually opaque and does not move up on deglutition or protrusion of the tongue. So this is a differential point between the dermoid cyst and the thyroglossus cyst. Once you have made the diagnosis, this is a thyroglossus cyst, it is very important to differentiate, is it a thyroglossus cyst or it is the ectopic thyroid. The investigation is you palpate the neck in the lower part, look for the glands if it's palpable or not, but the best thing is you can get an ultrasound. If the ultrasound shows that the thyroid gland is normally placed with both the lobes and isthmus, so it further confirms the diagnosis of thyroglossus cyst. And if there is any doubt about or equivocal, then the answer is the radioactive thyroid scan with I-131 scan that can able to appreciate that the thyroid gland is normally placed in its position, and this is a thyroglossus cyst. Anyhow, the ultrasound, the majority of the patient can able to detect the normally placed thyroid gland, or this is the swelling which is ectopic thyroid. Because when it is ectopic thyroid, then this is the only thyroid which moves, which is present in the body, and the source of thyroxine is this ectopic thyroid. When you get the ectopic thyroid, the answer is usually ectopic thyroid is presents with some degree of hypothyroidism, and the ectopic thyroid tissue is this genetic thyroid tissue which is more vulnerable to undergo a cancer change that is a papillary carcinoma of the thyroid. So the ectopic thyroid should be excised and put the patient on thyroxine. If it is a thyroglossal cyst, then answer is you have to do a operation. The name of the patient is called cyst trunk operation. That is en bloc resection, which consists of axion of the thyroglossal cyst. Second component is this axion of the central portion of the hyoid bone along with the thyroglossal tract going into the floor of the mouth, and you divide the tract also. This is called en bloc resection of the thyroglossal cyst, central portion of the hyoid bone, and the thyroglossal tract in the floor of mouth. Thyroglossal cyst can be a source of, can be site of recurrent infections, which can present as an abscess. Once the abscess is formed or recurrent inflammation or infection, and ultrasound shows there is an abscess, you can do the incision drainage, or with a white bore needle you can aspirate and give appropriate antibiotics and wait for 4 weeks before you excise later on. Or sometimes after incision and drainage, there's thyroglossal fistula develops. That is inadequate because the thyroid, the wall of the cyst is still there. You have to do the proper cyst trunk operation after a lapse of 4 to 6 weeks of the incision and drainage. The second complication of thyroglossal cyst is long-standing dysgenetic thyroid tissue is present in the wall of the cyst, and that is the patient is going to develop papillary carcinoma of the thyroid. So for these two reasons, one is the source of recurrent infection which lead to formation of abscess, and the second thing is the development of papillary carcinoma of thyroid. Once you diagnose a case of thyroglossal cyst, it must be excised. An incomplete excision of the cyst or a complete excision of the cyst without the excision of central portion of the hyoid bone leads to development of recurrence. So excision of the cyst should be complete, plus the central portion of the hyoid bone and the thyroglossal tract right up to the floor of mouth. So that is the treatment of the thyroglossal cyst. The treatment of sublingual, what is called dermoid cyst, below the level of the mylohyoid muscle, present as a swelling in the neck. The treatment is the excision of the dermoid cyst. It is cystic in nature because it contains just like a cheesy material, soft material. So dermoid cyst is excised in total. Regarding the pyramidal lobe, it is enlarged, which is diagnosed by the clinical test and ultrasound, and then the FNAC. This enlarged pyramidal lobe may be a site of a carcinoma. So if it is FNAC shows papillary carcinoma of thyroid, this pyramidal lobe, not only that should be removed, but the total thyroidectomy should be done. lymph nodes, if it is there, the answer is action of that lymph node and send for histopathology. The other swelling in the midline is at the level of the suprasternal space. This is called space of Burn. In this place, you can have got a solid swelling is lipoma. You may have got a dermoid cyst, or you may have got this pulsatile swelling of the innominate artery that sometimes is visible in a old people that show a pulsations in this area, and that is the brachiocephalic or the innominate artery that can be sometimes is visible as a mass, especially in the elderly people, but they has got a pulsatile. Regarding the segmental lymph nodes, you must look for any source of infection in the oral cavity, like caries of tooth, any ulcer in the mouth, tonsillitis, pharyngitis, sometimes the tooth abscess drains in the segmental lymph nodes, and these lymph nodes found large. Give him antibiotics and patient gets better. Rarely you can also find the lipoma in the segmental region. The other swellings in the neck, especially in the anterior triangle of neck, is the branchial cyst. Branchial cysts usually present as a rounded cystic swelling along the upper one-third of the anterior border of the sternomastoid. It's a cystic swelling. Sometimes it gives the impression of solid because the fluid is under tension. This is the embryological or congenital anomalies of second branchial cleft. This cystic swelling appears during a teenage group or in early adult life. Usually they are young patients. And the only point to differentiate at this area, is it a branchial cyst or cold abscess, because of the tuberculosis. The clinical, in addition to clinical examination, you have to look for other lymph nodes also. They are enlarged tubercular cervical lymphadenitis, if it's there, plus this cold abscess along the interior border, then diagnosis obvious that is a cold abscess. The second thing is that you should do a very simple investigation ultrasound to look for this area. Both will show it, they are cystic. It means either of the two is a cold abscess or a branchial cyst. Then the answer is you aspirate it. You aspirate the fluid just like a fluid which like a pus, or then you spread the fluids on the slides and you see under the microscope if there are cholesterol crystals. The diagnostic is branchial cyst. And if there are no cholesterol crystals, then simple the white blood cells or pus, it is a cold abscess. In branchial cyst, one of the complication is it can gets infected and can lead to abscess formation, and if you in CNN drainage, the patient develop fistula or sinus, disturbing sinus. The treatment of the branchial cyst is the action of the cyst. Tuberculosis or Caries abscess. Tuberculosis infectionitis lead to cold abscess. The treatment is anti-tuberculous drugs, and this disease will settle down its own. But if it is cold abscess does not settle down, you have to do an general anesthesia, make incision and drain the cold abscess and keratage the underlying caseating lymph nodes, which will further confirm the diagnosis by histology and the culture and sensitive to get appropriate anti-tuberculous drugs for resistant strain. The other thing is branchial fistula. That is also the congenital malformation of the second branchial cleft. This can present as a small opening on the anterior border of the lower one-third of the sternomastoid. Pinpoint opening may be 10% cases bilateral, present since birth, and there is a discharge of watery discharge or recurrent discharge, or sometimes the pus coming out it because of the recurrent infections. This branchial fistula you can palpate as a cord-like structure along the anterior body of the sternomastoid if it is a branchial fistula is a source of recurrent infections. It's lined by the epithelial lining, or maybe pseudo-ciliary epithelium. The treatment of branchial fistula is the axion of the fistula as it is accumulating up the lateral wall of the pharynx behind the tonsil. Majority of the cases it gets obliterated in the area of the lateral wall of the pharynx. You excise the fistula by making two horizontal incision. One is at a lower level of which can pass the opening of the fistula, and then you dissect the fistula and the track upwards and make another incision just below the ramus of the mandible. This branchial fistula, if you trace the track, it runs along the anterior part of the sternomastoid, going up in front of the bifurcation of the common carotid artery, and then it goes towards the lateral wall of the pharynx. The structure which are related is the common carotid artery, the hypoglossal nerve, and the glossopharyngeal nerve. And lower down you can also in vicinity of the internal nuclear vein. So these structures, they come in your way when you are going to dissect the thyroglossal, this branchial fistula. And step-ladder fashion incision is made, two horizontal incision. The structure which are vulnerable to be damaged is the internal jugular vein, the common carotid, as it passes in front of the hypoglossal and the glossopharyngeal nerve. They are also vulnerable to be damaged. So one should be very careful while you are doing this ablation for the axion of the branchial fistula. The other swelling in the posterior triangle of neck is the enlarged lymph nodes. When you get the enlarged lymph nodes in the posterior triangle of the neck, you must examine the lymph nodes. Clinical examination of the lymph nodes is very important. You see also on the opposite half of the neck and also the axilla and groin. A large lymph node, there are three possibilities. One is the recurrent infection or recurrent lymphadenitis, which leads to chronic lymphadenitis, and then we must sort it out the source of infection in the oral cavity, as the caries of the tooth or any other source of infection in the scalp of the face. These enlarged lymph nodes may be due to the HIV infection also. One should be carefully examine it and take a proper history and examination. By and large, there are three possibilities in addition to chronic non-specific lymphadenitis. One is the TB, tuberculous lymphadenitis. Second important thing is the lymphoma. And if the lymph nodes also are large and they are just firm, is maybe a secondary deposits. So these three things you keep in mind when you get the enlarged lymph node. When the supraclavicular lymph nodes are large, there are two strong possibilities. One is the lymphoma, they are fleshy, large, skitted or sometimes matted. And the second is the secondary deposits. Paramis may be somewhere in the head and neck or below the infraclavicular, may be the breast, lung. On the left side, this enlarged lymph node may be draining the abdominal and pelvic malignancy. How you will treat these cases. So if you think this is a tuberculous lymphadenitis, you should do the X-ray chest, ESR, monospot test is positive. And if you suspect a lymphoma, the best investigation is the excision of the lymph node under general anesthesia and send for histopathology of the lymph node, which will reveal lymphoma. If you suspect this is second deposits, it is very much important that you should thoroughly examine the head and neck, the scalp, face, the parotid areas, and of course open them out and look for the inspection of the oral cavity, the tongue, cheek, mucosa, buccal, alveolus sulcus, and also the area of the tonsils and the base of the tongue. In addition to that, it's very important to have got if you don't find any lesion in this area, the ENT surgeon should take up this case and search for any primary hidden lesion in the upper aerodigestive tract. Sometimes you have to take the random biopsy of the nasopharynx and the base of the tongue. Pen endoscopy may be required at times to look for a hidden lesion in the upper aerodigestive tract, which can cause secondary deposits in the deep cervical group of lymph nodes. If you could not able to find out clinically, then the answer is you have got certain systems of investigations. That is laboratory investigations, is full blood count, ESR, monospot test, and the radiological imaging ultrasound, CT scan, MRI of that area, which can able to pick up the heterogeneity of the lymph nodes in addition to primary focus anywhere in the upper aerodigestive tract, which can be picked up by MRI or CT scan. With all these investigations, no clue is found. Answer is you should do the FNC of the cervical lymph node. It will let you know that this is a saccharine deposit because of squamous cell carcinoma or the adenocarcinoma. 80% of the cervical lymph node saccharine deposit is the squamous cell carcinoma, which is rising from within the oral cavity of the oropharynx, that is the base of the tongue, posterior pharyngeal wall, and the palatine tonsil or hypopharynx, piriform fossa, area-epiglottic fold, or nasopharynx. These are the sites which are hidden, and the lesion is primary lesion is too small to be picked up, but it can present with massive cervical metastasis. The primary is known, it is squamous cell carcinoma in the hidden areas. You can irradiate after doing the biopsy of that area. You can irradiate the hidden area plus the irradiation to the neck. Treatment of primary and the secondary at the same time with the irradiations. You think the primary irradiation and the lymph node burden is much more, then answer is you can do the modified block dissections. Afterwards, when you treat the primary with irradiation or the saccharine deposits after irradiation, the residual tumor left over, you can do the modified block dissection. And if the biopsy shows lymphoma, then you have to know histologically type of lymphoma, Hodgkin, non-Hodgkin, and then you stage the disease by doing the CT chest, abdomen, and also the bone marrow aspiration for staging of the disease, and then treat accordingly with the anti-cancer drugs. Both are available, Hodgkin and non-Hodgkin lymphomas, by the medical oncologist. So that is about the swelling, the cervical lymph nodes. Then other swelling, you can see the interior triangle is the carotid body tumor. The carotid body tumor usually present as a neck swelling in the carotid triangle at the bifurcation of the common carotid artery at the level of the hyoid bone. Sometimes it is misdiagnosed as a large lymph node. This swelling occurs in the middle age group, slowly grows very slowly, involving and the growth is usually upwards towards neck. This swelling is firm to hard, surface is smooth, just like a potato. It's also known as potato tumor. One of the most important things is you should be very careful and don't take it as a lymph node unless otherwise ruled out. You palpate it, you find there is a transmitted pulsation. Put the index finger of both the hands and you will see there is a transmitted pulsations. But if this is an aneurysm, the pulsation will be expansile. That is, the finger will move in horizontal direction. Place the finger there, you will find you can see the pulsation like this. In this case, you see the pulsation like this. So this carotid body tumor, I have seen a few patients which has been taken as a large lymph node, taken under general anesthesia, excised the lymph node, it results in torrential hemorrhage and bleeding. They put stitches there and they tie the common or the internal carotid artery, and the patient develops hemiplegia. So one should be very careful. Don't put the needle when you suspect a carotid body tumor because it can lead to torrential hemorrhage. The best thing, get an ultrasound first. You know that this swelling is vascular or non-vascular, and Doppler study will let you know that this is a carotid body tumor or not. So Doppler study is must. No FNAC until you do the Doppler ultrasound for this carotid body tumor. The treatment of carotid body tumor is 10 to 20% maybe metastatic, but usually they are benign. They grows. Sometimes the patient complains of syncopial attacks when you slight pressure on it. The heart rate slows down and patient has got a syncopial or the attacks. The treatment is you excise the carotid body tumor, but it should be dealt by the vascular surgeons. Availability of the placement of shunt if need arise, but you have to excise very carefully. And if there is a puncture on the internal carotid artery, you have to stitch it while the patient is placed on shunt. That is from the common carotid to the internal carotid artery to bypass the blood flow, and then you can also do this operation very comfortably. You dissect the whole carotid body tumor, and if there is any puncture in that, you can stitch it while the flow is bypassed from common carotid artery to internal carotid artery, and that area is totally secluded for ablation. So that is the other important thing which you should not miss it, and be careful. Is it a carotid body tumor or it is a large lymph nodes? So that is one swelling the neck which can end in disasters for the surgeons who take it as a large lymph node. You palpate any swelling, is a pulsatile or non-pulsatile. Is pulsatile, it is a transmitted pulsation, or it is the swelling itself is the vascular, like aneurysm, like AV fistulas, or it's a transmitted pulsation, especially in the area of the hyoid bone in the anterior neck. It's a carotid body tumor. One thing you should always keep in mind: never miss the vascular lesion, because if you excise them or you puncture them, it will end in disasters. Other important swelling may be in the neck, may be lipoma anywhere, and the swelling may arise from the nerves, because there is a cutaneous nerve plexus, cervical plexus there is a hypoglossal nerve, there is a vagus nerve, and there is also cervical plexus and the roots of brachial plexus. The swelling which arising from these nerves are neurofibroma, ganglioneuroma, or paragangliomas. May arise from a sympathetic nerve, cervical plexus, vagus. This ganglioneuroma, neurofibroma, these swelling, if you palpate this swelling, you find They can move in the longitudinal axis, but they cannot move the swelling in the horizontal fashion. And non-pulsatile, arising from nerve sheath, that you should keep in mind. Ganglioneuroma, neurofibroma, or the paragangliomas. The other swelling which you can get in the neck is the lymphangiomas, or in children like cystic hygroma. It is a lymphatic multinodular multiloculated cyst which contain the lymph, and that lymph has been cut off from the main lymphatic trunks. It's just like the islands of the lymph with multiple septations. Usually arise in the posterior triangle of neck, can extend towards the face also, or it can extend infracranially towards the axilla or the mediastinum. Transillumination test is brilliantly positive. This lesion is not proliferative but it can infiltrate the tissues in the surrounding tissues. Small lymphangioma, they disappear as the person grows up, is grown up. Some lymphangioma, they are big size, cosmetically, and second, may be source of infections, and they get suddenly enlarged if there is any infection in the oral cavity because of the increased lymph in that area, increased flow of lymph in that area. Transillumination test is positive. The treatment is, if they are small size, leave alone. It may disappear as the body grows up, that size. If the lymphangioma is very large size and cosmetically is not acceptable, the answer is there are two options. As the operation requires a meticulous dissection with full complete hemostasis with bipolar diathermy, because sometimes it gets punctured, which is likely to occur. Second thing is that complete excision is not possible. Rather, it is exceptional. And the recurrence is the rule, because you can't excise the whole lymphangioma or the cystic hygroma completely. It regrows again. So, majority of people, they would prefer to give a sclerotherapy, and the sclerosing agent which used nowadays is OK432, which is the lyophilized streptococcal and the penicillin G potassium. This is lyophilized fluid, and this sclerosing agent is injected into the lymphangioma, and that can cause fibrosis and obliteration of the swelling. If it is small size or moderate size, it's a huge swelling is in the neck, then answer is excision is done, but be careful to avoid the injury to the marginal mandibular branch of the spinal fascia, because these lymphangioma occur either in the submandibular region or in the posterior trunk. That is all about the common swellings in the neck. Another swelling is also there in children after breech delivery. 20-30% of the cases is swelling in the sternomastoid, which is formed too hard, which is a hematoma in the sternomastoid, which presents later at torticollis. If it is picked up, you should start physiotherapy and the motion exercise. Sometimes it is neglected and present as a mass in the sternomastoid. On that side, the sternomastoid is shortened and the head is turned towards the opposite size, and the head is abducted on the ipsilateral side. This is a complication of breech delivery or trauma in 25 to 30% of the cases. Initial phase, motion exercise, and then later on, if the torticollis is developed and patient is not responding, you have to do the tenotomy of both the sternal and clavicular head of the sternomastoid. And that is usually seen in children. And that is called torticollis with presentation of a mass in the sternomastoid. And the last and the least, one should not miss it, skin lesions, especially the epidermoid cyst or sebaceous cyst, can be present as a swelling in the neck. And the treatment is enucleation of the sebaceous cyst or the epidermal cyst, which is a cutaneous lesion as a result of the blockage of the duct of the sebaceous gland, which leads to sebaceous cyst in the skin of the neck. And if it gets infected, it can present as an abscess. The treatment is incision drainage and removal of the wall of the cyst. That is all about the common neck swellings. Of course, you should remember also the submandibular triangle is the submandibular salivary gland, which can present as a recurrent attacks of sialadenitis, or the submandibular gland tumors may be a pleomorphic adenoma or the carcinoma of the submandibular salivary glands. Of course, in the neck, there is also tail of the parotid at the superior border, which can descend into the neck, from where you can have a pleomorphic adenoma or adenolymphoma Warthin tumors. They can present as the swelling at the superior border of the neck it can present as a swelling which basically arising from the tail of the parotid, which may be pleomorphic or may be Warthin tumors. That is all about the common neck swellings. Few things you should remember. It is very important to inspect the swelling, palpate the swelling, and find it out. Think about it. Is swelling related to the skin, the subcutaneous tissues? Is it a lymph nodes? It is a salivary glands? It is a vascular swelling? It is a non-vascular? So all these things you should keep in mind, and then you make your provisional diagnosis, which must be assisted by the investigations, which may include the blood laboratory investigation or radiological imaging like ultrasound, CT or MRI. And then, of course, the swelling should be excised and sent for histopathology to confirm your diagnosis.